we will be forced to do a stop bank score on you and then start treating your sleep apnea if you snore. So there we go. So first thing, I'm speaking on behalf of Novo, and I have no other conflicts of interest to declare, and I have no conflicts of interest as to the scientific content of this talk either. So do we have a laser pointer? Excellent. Okay. So I'm going to break down my talk into a few sections, talk about why we need to think about weight management in diabetes, then talk about the pioneers studies with semaglutide, talk about the benefits with semaglutide in terms of glycemic and extra glycemic benefits, and then sum it up. So our approach to diabetes, and we do it well, has always been to manage the glucose. But if you look at the natural spectrum of, forget diabetes, the cardiometabolic disease that we are now facing, the problem starts much further upstream, where we have obesity, multifactorial, obviously, environment, genetics, diet, lifestyle, everything else. But if we manage this obesity, we are managing the root cause of the problem. If we leave it further downstream, we then start seeing the downstream cascade of hypertension, diabetes, coronary artery disease, and everything else. As I said, the sleep apnea. So snore away and we'll evaluate the liver-related NAFLD and NASH, arthritis, dyslipidemia, the cancers, infertility, PCOS, all the downstream effects of PCOS depending on, obesity, depending on your weight and stage of life. The glucocentric approach has worked well for us, but we know that with the glucocentric approach, we haven't really made any major changes, for example, to cardiovascular outcomes. Whereas treating upstream and having a weight-centric approach, if it's early diabetes, will help us modulate the course of the disease. And if it is not yet diabetes, being aggressive with weight management may actually allow us to modulate the whole spectrum of cardiometabolic disease for any given individual. So more and more we should be thinking of the wasted opportunity of trying to manage upstream and address the problem there. So if you look at managing the weight, number one, as I said, you can actually disrupt the underlying pathophysiology, and if it is early in the disease, you may be able to reverse or slow down the progression of the disease. The second thing is, even by the time we have dysglycemia, whether it's diabetes or just at the state of, let's say, pre-diabetes, you can certainly improve the markers of blood glucose, and you'll be able to modulate the cardiometabolic risk factors, the dyslipidemia, the hypertension, and the other factors. What this means is that downstream, you will be able to improve or prevent the micro and macrovascular complications of this pathway. So if we treat weight, at least at the stage of diabetes, if not earlier, we know that we can make a huge difference to the outcomes for any given individual. Once we get to the stage of diabetes, we have multiple drugs that we use for glycemia, but not all of them are equal when it comes to the extra glycemic risks and benefits. So if you look at efficacy, you know that insulin is perhaps the most efficacious. Insulin is perhaps the most efficacious, for your money, it gives you the best A1C reduction, followed by sulfonylureas. But if you look at the hypoglycemia risk, exactly because these are very effective molecules, you have a high risk of hypoglycemia with both sulfonylureas and insulin. And when it comes to weight, we know that although they're effective, insulin and sulfonylureas are both quite bad in terms of being offenders for weight gain. CV benefit, it's only in the last decade or so that we're actually looking at CV outcome trials and looking at the CV benefit of the molecules that we're using, and we certainly have the wealth of evidence exists for SGLT2 inhibitors and now GLP-1 receptor agonists. But if you put this all together, if you're looking for molecules that are fairly effective, intermediate to high efficacy, with a low risk of hypoglycemia, with a low risk of weight gain, or better still, benefit, you want to see weight loss and good CV outcomes, then you're effectively looking at your SGLT2 inhibitors and your GLP-1 receptor agonists. but more importantly with your GLP-1 receptor agonist, because you get good weight loss. In fact, with the newer agents, maybe equivalent to bariatric surgery, with a low risk of hypoglycemia and established CV outcomes. So in one molecule, in one group of molecules, you have good efficacy, low risk of hypoglycemia, weight loss, and CV benefits. So why do we go on about weight loss? Because in people with diabetes, if you get them a minimum of 5%, but up to 15% weight loss, you can see a huge improvement in their quality of life, a good effect on disease modification. As I said, you can alter the path of these cardiometabolic disorders. You will see metabolic improvement, and you will see a reduction of their cardiometabolic risk. So as little as 5% will start you off, but obviously the more you get, the better. When you're looking at improvement in, say, NAFLD or sleep apnea, you do need at the higher end of this, you need the 10 to 15% or even more, but you will start seeing cardiometabolic benefits from about a 5% weight loss. So how do the GLP-1 receptor agonists give you this benefit? Well, number one, we talk about the effect at the gut level. We know that it slows down gastric emptying, it improves satiety, but they also have a direct effect on the brain in terms of appetite regulation and weight loss. The GLP-1 receptor agonists, so they actually stimulate your pro-opiomelanocortin pathways and your CART pathways, and they decrease your hunger and energy intake, and they decrease cravings, and so they decrease your snacking and grazing between meals. On the other hand, they inhibit neuropeptide Y and AGRP, and what this does is it promotes satiety. So on the one hand, they decrease hunger and they decrease calorie intake. On the other hand, they improve satiety so that it prevents overeating. So from both points of view, they actually leave people feeling full, not craving, not snacking, and help weight loss. So if you look at weight loss therapies, you want sustainable weight loss with effective glycemic control, something that addresses the long-term glycemic risks with a minimal risk of hypoglycemia. And this is the space in which your GLP-1 receptor agonists perfectly come into play, that addresses the gap between these three requirements for weight loss. So if you look at clinical efficacy, they're highly effective in terms of A1C reduction. In fact, the higher you start, the better the A1C reduction. They're excellent in terms of body weight reduction. You see a minimum of 4 to 5 kilos, but with aggressive lifestyle management, you can see more than that. In fact, just yesterday I saw a couple, between them they've lost 15 kilos since January. The husband lost about 8 point something, and the wife lost about 7 kilos. So between them, they've lost 15 kilos. This is the kind of effects that you can see. Although the clinical trials tell us 5, you push on the lifestyle, you can get more. They have a very low risk of hypoglycemia. The main risk of hypoglycemia comes from combining them with SUs or with the insulin. And they have established CV benefits, and I'll show you the data for that. The other benefit for these agents is, once you up titrate to the correct dose, and I'll show you slides on how to start and maintain this particular molecule, the semaglutide, you don't need to dose adjust any further. There is an attenuation of side effects. So the nausea, the GI side effects that you see in people, with adequate counseling and with management of those symptoms, they actually attenuate, and they're quite well tolerated. So the titration is stepwise and easy. Once you get them to dose, there is no further titration or adjustment required, and they're quite well tolerated as long as you do the counseling and dose titration appropriately. So when you look at this kind of a molecule, you could say, why aren't more of us using it? In India, we don't have the data, but this is data from the US. And what you can see is that a majority of people with type 2 diabetes would qualify for using GLP-1 receptor agonists. However, less than 10% are actually using it. So there is a huge gap between who would be eligible and who's actually getting the molecule. Part of this can be cost, part of this can be our comfort level with prescribing and adjusting, and part of this can be multifactorial. But we should really be thinking of using these molecules early on and giving the patients the benefit of the long-term cardiometabolic risk modulation. So now coming to the evidence. Now, you know that, even with liraglutide, the lead program with Levemir, Novo has this very strong pathway of building up the evidence, and that's no different for semaglutide. Pioneer 1 tests semaglutide against a placebo, Pioneer 2 against SGLT2, Pioneer 3 against DPP4, Pioneer 4 against liraglutide. Pioneer 7 actually reflects what we do in real life. Not everybody is going to go 3, 7, 14. What happens if you have a flexible dose? What if they only get to 3 because of other reasons, nausea, GI side effects, or only get to 7 and they can't increase beyond that? Well, Pioneer 7 addresses that. Pioneer 8 is an add-on to insulin. Pioneer 6 is with renal impairment. Pioneer 5 with renal impairment, and Pioneer 6 looks at CV outcome trials. Now, both the Pioneer 8 and Pioneer 6 have a decent proportion of Indian patients in them. Pioneer 9 and 10 look at outcomes in Japanese patients, and the SOUL study, which is their CV outcome trial, is ongoing, and again it has just under 800 patients from India. So, I'm going to show you benefits from A1C, weight, and blood pressure and other effects. So, if you look at A1C, so I said monotherapy. Now, you might say, will we really use it as monotherapy? In diabetes, we are probably going to use it along with metformin, let's be real, but it's good to have that data with monotherapy. You can see that semaglutide 14, which is the maintenance dose, gives you an A1C reduction of 1.5%. Versus empagliflozin, about a 0.5% extra, 1.3% in terms of absolute. You can see versus sitagliptin versus liraglutide, even when you compare it head to head with another GLP-1 receptor agonist, it still gives you a little further, another 0.3 extra reduction of A1C. For all of you taking photographs, please don't mind me saying this, but I'm happy to send the PDF out, and I'm sure that Novo will be happy to give a PDF for the slides. So please don't bother taking photographs. You can have the presentation. I'm happy to give it to you right here. Email me or take it from here, and then I'll give it to you, no worries. And with insulin, this is again a scenario. I quite often combine GLP-1 receptors with insulin, because not only does it mitigate the weight loss, it gives you another additional A1C benefit and additional weight loss. So both from an A1C point of view and from a weight point of view, combining it with insulin and having the evidence, as you can see over there, is quite useful. So that is the A1C reduction. Now, sorry, that's moving, not moving. No, it didn't move. My slides are stuck. Okay, now it's moving. Okay. So, in total, you see an average of 1.5. It's moving now. In total, you see an approximate 1.5% reduction in A1C. Now, looking at, remember where I said if the A1C is higher, it works better. So, if you start with an A1C over 9, the proportion of patients who started with an A1C over 9 uniformly have an approximate 2 to 2.5% reduction. As monotherapy and elsewhere, 2 to 2.5 reduction, even when combined with insulin. So, the higher you start, the better the bang for your buck with this particular molecule. So, baseline about 2.5% if you use it as monotherapy, and otherwise about 2 to 2.2%. Now, weight reduction. So, if you look at weight as monotherapy, you will see compared to placebo, there is a weight reduction of approximately 4 kilograms with semaglutide at the dose of 14 milligrams once daily. Versus empagliflozin versus liraglutide, because these are two agents which we know already give you weight benefits, 3 kilos, 3.5 kilos on their own. Even over and above that, you will see an extra reduction in weight when you use semaglutide. And this is what I was saying, when you combine with insulin, where the usual scenario is weight gain when you introduce insulin, if you introduce it along with a GLP-1 receptor agonist with semaglutide, you see approximately a 4 kilo weight loss. So on its own, on a background of diet and exercise, in combination with various OADs and on a background of insulin, you can see that semaglutide gives you consistent weight loss of approximately 5 kilos. But as I said, this is clinical trial experience. In real life, if you're aggressive with the weight management, you can do more than that. You can do approximately this in 3 months, and then you can keep going to do more. So a 1.5% reduction in A1C, approximately a 2 to 2.5% reduction in A1C if you start with an A1C above 9, and approximately a 5% reduction in weight. This is the efficacy as far as weight and A1C is concerned. Now looking at other things. We know that if you have a 5 to 15% weight loss, as I said, you will see an improvement in all of these. But how many patients actually get there? Well, 50% of patients get to a more than 5% weight loss, and about 20% of patients get a 10% or more weight loss. So while we know the metabolic benefits, it's important to know how many people get there. Well, 50% will get to a 5%, and about 20% will get to more than 10% weight loss. The more important thing is when you talk about weight loss, you want to see fat loss and not muscle loss. So with semaglutide, when you see a weight reduction, as you can see, what you see is fat loss, body fat mass, not lean mass. So comparatively, you preserve your muscle and you lose body fat. So that's the other advantage with semaglutide. Part of how that happens is that there is less, as we showed you, the appetite goes down, there are less food cravings, and there's a better control of their eating behavior. And there is a lower preference for energy dense fatty foods. In fact, if your patients get nausea, one of the ways of telling them is actually to try and avoid those fatty foods. The nausea improves. So these behavioral changes and dietary options, if you will, their choice of diet, actually helps them lose more fat and preserve the muscle mass. So again, looking at extra glycemic, we want to see that metabolic improvement, right? So let's show you. You will see that there is an improvement in blood pressure with systolic improving by about 10 to 12 and your diastolic coming down by 2 to 4 to 5. You also see an improvement in your triglycerides and an improvement in your HDL levels going up by approximately 4 to 6 and your LDL levels coming down equally. So there is an improvement in your lipid profile. And this then translates to an improvement in your CV risk over a period of 10 years. So other metabolic factors, your hsCRP, which we know is a marker for cardiovascular disease, comes down. I've shown you the improvement in lipids and the improvement in systolic blood pressure, but your waist circumference as a marker for visceral adiposity comes down by about 5 centimeters. So 4.7 centimeter reduction in your waist circumference. So consequence of all of these, there is an improvement in quality of life. For every 1 unit in BMI that they decrease, there is an improvement of approximately 0.02% in terms of your quality of life. Then coming for, remember where I said the earlier we start, the more benefit we are giving our patients? Well, if we start early, a higher percentage of patients achieve goal. So if you look at the composite outcome of the number of people that achieve an A1C under 6.5 plus the amount of people that lose more than 5% body weight, if the duration of diabetes is less than 1 year in the darker color versus more than 1 year, you'll see that at every dose, a higher percentage of people actually achieve goal if you start early. So start early and give them the benefit. This is Pioneer 1, which looked at semaglutide at the diagnosis as monotherapy. So give them the benefit of improving all these cardiometabolic outcomes. And 8 out of 10 people achieve goal overall. You can see less than 7% of A1C, 80% of people, and weight loss more than 55%, still about 50%, 44% of people achieve this. So the earlier you start, the better your results. More patients achieve an A1C of 6.5, under 7, 80%, and weight loss more than 5, at least about 50%. And then we know that early treatment, the legacy effect if you will, actually improves your outcomes longer term. Good glycemic control reduces, we were talking about this just a few minutes ago at lunch, how we don't talk enough about the benefits of reducing your healthcare costs. So early glycemic control, reduction of your diabetes related and cardiovascular related complications longer term actually improves your healthcare costs and reduces your healthcare burden. So over the course of your Pioneer trials, What we've seen is that there's a large database of patients, nearly 6,000 patients, 5,700 patients who've used semaglutide. So there is proven safety. The most common side effects are gastrointestinal, but these are mild to moderate, and with adequate counseling and changes in diet, they're easily tolerated. Well, not easily, but they are tolerated, and you can counsel your patients through them and manage them symptomatically. As with other GLP-1 receptor agonists, this molecule is associated with a very low risk of hypoglycemia. And with semaglutide in the oral format, there have been no new surprises compared to the other GLP-1 receptors in terms of safety signals, and it's equally well tolerated. So good tranche of safety and tolerability data with proven combinations across the pioneer trials, with proven efficacy against various other OADs and in combination with insulin. You can use it safely in the elderly, in patients with hepatic and renal impairment, and in patients with upper GI tract disease. So there's no dose adjustment required across any of these spectra of diseases. Now comes the practical bits. This is very, very, very important. How do we tell patients to take, good, I still have 9 minutes. How do we take patients to take semaglutide? They must take it in the morning with no more than 120 ml of water. This is important. So you must tell them 1 to 2 sips of water at the most. And after that, they need to stop eating or drinking anything. Tea, coffee, water, everything for exactly 30 minutes minimum. So take it with 1 to 2 sips of water, and then don't eat or drink anything, including water, for at least 30 minutes. And then eat normally. We say eat normally, we mean eat healthy, but you will find that patients automatically, their pattern and their preferences for food changes with semaglutide. So 1.5% reduction in terms of A1C, 5 kilo weight loss, 5 mm of systolic blood pressure, improvement in your lipid parameters, and improvement in your waist circumference. This is what I've shown you so far. So to summarize, semaglutide is the first oral GLP-1 receptor agonist that we have. I've shown you data in terms of efficacy, glycemic efficacy, and weight across comparators, including head-to-head against SGLT2 inhibitors and liraglutide. It works better in terms of A1C and weight reduction. I've shown you the benefits of weight reduction, and I've shown you the sustained weight loss modulating cardiometabolic risk factors with this use. The extra glycemic benefits in terms of weight loss, in terms of adiposity, reduction in waist circumference, and improvement in the other cardiometabolic parameters. And finally, I've shown you the safety for using again in a spectrum of disorders in the elderly, across renal and hepatic impairment, and in people with the upper GI tract problems. But most importantly, please remember how we dose this. Empty stomach, half an hour, nothing after that, 1 to 2 sips of water. Thank you very much.